The Index of Orthodontic Treatment. Need. IOTN. Dental Health Component, DHC. Welcome to this lecture on the Index of Orthodontic Treatment Need, or IOTN. In this video, we'll explore one of the most important clinical tools in orthodontics, the Dental Health Component, or DHC, which helps us objectively determine how severe a patient's malocclusion is and how urgently they need treatment. By the end of this video, you'll understand how to apply the DHC, how to interpret each grade, and why it remains a cornerstone of modern orthodontic assessment. 1. Overview and historical context. The Index of Orthodontic Treatment Need. IOTN was developed by Brooke and Shaw in 1989, University of Manchester, to create an objective, reproducible standard for identifying who needs orthodontic treatment from a health perspective, not just for aesthetics. Before the IOTN, orthodontic case selection was highly subjective, varying among practitioners. Public healthcare systems like the NHS required a standardized, evidence-based index to prioritize limited resources for patients with true dental health risks. Thus, IOTN consists of Dental Health Component, DHC, measures physical functional impact. Aesthetic Component, ASTHET, measures psychosocial aesthetic impact using 10 photographic grades. 2. The conceptual basis of the DHC. The dental health component assesses malocclusion as a disease risk, not as a cosmetic irregularity. It focuses on how malocclusion affects oral function, mastication, speech, swallowing, tissue health, gingival trauma, caries risk, tooth eruption and alignment, impactions, crowding, facial growth, and occlusal harmony. It's structured hierarchically. The worst occlusal feature determines the overall grade. This ensures that no significant health-related problem is overlooked due to averaging or weighting. Detailed breakdown of the DHC grading system. Grade 1. No treatment need. Extremely minor malocclusions including displacements less than 1 mm. Essentially normal occlusion or ideal alignment. Slight rotations or less than 1 mm crowding are clinically insignificant. No impact on function, hygiene, or appearance. Treatment would be purely elective. Example. A patient with perfect molar relationship, ideal overjet, 2-3 mm, minimal irregularity. Grade 2. Little treatment. Need mild deviations from normal occlusion that do not compromise health or function. Key features. Overjet more than 3.5 mm but less than or equal 6 mm with competent lips. Lips can close without strain, so trauma risk is low. Reverse overjet less than or equal 1 mm, minimal anterior crossbite. Crossbite, less than or equal 1 mm discrepancy between retruded and intercuspal positions, minor centric slide. Displacement of teeth more than 1 mm but less than or equal 2 mm. Mild crowding. Open bite more than 1 mm but less than or equal 2 mm. Increased overbite more than or equal 3.5 mm without gingival contact. Half-unit molar discrepancies without other issues. Clinical meaning, these cases are stable and functional. Treatment is optional or aesthetic-driven, e.g. minor crowding correction or alignment. Grade 3. Moderate treatment. Need. Moderate irregularities causing some functional or aesthetic concern. Key features. Overjet more than 3.5 mm but less than or equal 6 mm with incompetent lips. Lips cannot meet passively, causing trauma or aesthetic concern. Reverse overjet more than 1 mm but less than or equal 3.5 mm. Crossbite more than 1 mm but less than or equal 2 mm discrepancy. Displacement more than 2 mm but less than or equal 4 mm. Open bite more than 2 mm but less than or equal 4 mm. Complete overbite without gingival palatal trauma. Why this matters: lip incompetence increases risk of incisor trauma and desiccation. Moderate crossbite or open bite may cause functional shifts, muscle strain, or speech difficulties. Mild displacement crowding may compromise oral hygiene over time. Interpretation. Treatment justified to prevent deterioration or improve function, not urgent but advisable. Grade 4. Great treatment need. Definite malocclusions with significant functional, dental, or developmental risk. Key features. Overjet more than 6 mm but less than or equal 9 mm. Reverse overjet more than 3.5 mm, no speech mastication issues yet. Crossbite, more than 2 mm discrepancy, functional interference likely. Severe tooth displacement more than 4 mm. Open bite more than 4 mm. Overbite with gingival palatal trauma. Less extensive hypodontia, missing 1-2 teeth needing space management. Posterior lingual crossbite with no occlusal contact on both sides. Reverse overjet, 1003.5 mm with speech or masticatory difficulty. Partially erupted or impacted teeth excluding third molars. Supplemental supernumerary teeth causing eruption disturbance. Clinical impact. These patients are at risk for soft tissue trauma, functional occlusal interferences, abnormal tooth wear, eruption failure or impaction, compromised mastication or speech. Treatment is necessary to maintain oral function and prevent pathology. Grade 5, very great treatment. Needs severe malocclusions with clear dental, functional, or developmental pathology. Key features: overjet more than 9 mm. Extensive hypodontia, more than one missing tooth per quadrant, affecting occlusal support. Impeded eruption due to crowding, supernumerary teeth, retained deciduous teeth, or pathologic obstruction, e.g. cyst. Reverse overjet more than 3.5 mm with speech masticatory difficulties. Cleft lip palate defects, submerged deciduous teeth infraocclusion, clinical implications, severe skeletal or dental discrepancies. Often require multidisciplinary management, orthodontic plus surgical, orthodontic plus restorative, orthodontic plus speech therapy in cleft cases. Treatment urgency, essential to restore function, health, aesthetics, and psychosocial well-being. 4. How to apply the DHC in clinical practice. Step 1. Examine systematically. Evaluate sagittal relationships, overjet, reverse overjet, transverse discrepancies, crossbites, vertical discrepancies, open bite, overbite, displacement and rotations, tooth absence or eruption problems, any soft tissue trauma. Step 2. Identify the single most severe feature. The rule: the highest single trait determines the grade. This ensures a small but clinically critical problem, e.g., impacted canine is not downplayed by other minor features. Step 3. Assign the DHC grade 1 to 2, no little need. Grade 3, borderline moderate need. Grade 4 to 5, definite or very great need. 5. Clinical significance of each feature: overjet normal, 2-3 mm. More than 3.5 mm means aesthetic and trauma risk. More than 6 mm means lip incompetence, trauma, class 2 risk. More than 9 mm means high trauma and psychosocial risk. Reverse overjet indicates class 3 malocclusion, functionally and aesthetically severe. Crossbite indicates transverse discrepancy or mandibular shift. May cause premature contacts, functional deviation, TMJ strain, asymmetric facial growth. Open bite reduces incisal guidance. Affects speech, especially S and T sounds. May relate to tongue thrusting or skeletal issues. Overbite. Deep overbite can lead to palatal trauma, lower incisor mobility, gingival stripping. Displacement reflects crowding or rotation. More than 4 mm may obstruct eruption or compromise hygiene. Hypodontia and impactions indicate need for interdisciplinary care. Impacted canines or multiple missing teeth demand space management or prosthetic planning. Rating 6. Comparison with aesthetic component, AC, according to purpose, dental health component, functional. Health aesthetic component, aesthetic psychosocial, according to scale. Dental health component grades 1-5 aesthetic component, photos 1-110. According to measurement, dental health component. Clinical indices, millimeter eruption, trauma. Aesthetic component, visual appearance, according to used by dental health component clinicians. Aesthetic component clinicians plus patients. According to objectivity, dental health component. High aesthetic component, moderate, according to priority use. Dental health component, NHS. Insurance aesthetic component, complementary assessment. 7. Clinical examples, deep case analysis. Case A, 5 mm overjet, competent lips, mild crowding 1.5 mm. Means grade 2, little need. Case B, 5 mm overjet, lips incompetent, mild trauma to upper incisors. Means grade 3, moderate need. Case C, 7 mm overjet, gingival trauma, minor impaction of upper canine. Means grade 4, great need. Case D, 10 mm overjet, anterior open bite, 5 mm, speech distortion. Means grade 5, very great need. 8. Limitations and criticisms. Does not account for psychosocial distress, hence the separate aesthetic component. Inter-examiner variability still possible, borderline cases. Cultural differences affect perception of need. Does not fully capture functional asymmetries or minor TMJ dysfunctions. 9. Clinical importance in public health. In the UK NHS, treatment is funded only for DHC grades 4 and 5 or grade 3 with AC more than or equal 6. This ensures that public orthodontic resources are allocated to patients who clinically need it, preventing cosmetic misuse of services. Integration in modern orthodontics today. IOTN DHC remains one of the most globally recognized indices used in epidemiological studies to measure population need, clinical audits to evaluate treatment outcomes, policy frameworks, insurance or government funding. Newer indices, like the ICON, Index of Complexity, Outcome, and Need, integrate IOTN principles but expand to evaluate treatment complexity and results. Look at all Evan. Summary Table Grade 1. Overjet feature less than 1 mm displacement. Clinical implication. Ideal occlusion treatment. Urgency. None. Grade 2, overjet feature 3.56 mm competent lips. Clinical implication, mild aesthetic treatment. Urgency optional. Grade 3. Overjet feature 3.56 mm incompetent lips, mild trauma. Clinical implication, functional concern treatment, urgency advisable. Grade 4, overjet feature more than 6.9 mm or impaction. Clinical implication, risk to health function. Treatment urgency, strongly needed. Grade 5, overjet feature more than 9 mm. Clefts, multiple impactions. Clinical implication, pathological treatment, urgency essential. 12. Conclusion. The dental health component of IOTN provides a scientific, reproducible framework for assessing malocclusion severity in terms of dental health and function. It is indispensable in orthodontic diagnosis, treatment planning, and public policy. When used alongside the aesthetic component, it ensures a balanced clinical and psychosocial judgment for patient care. Thank you for watching. If you found this lecture useful, don't forget to like, subscribe, and explore our channel for more orthodontic learning content.